I'd like to tell you a story about three women: myself, Josephine, and Esther. The story takes place in Togo. Now, if you've never heard of Togo before, stay with me here, because I was in your shoes back in 2014. I had just graduated from college with a degree in sociology and global health, and I was fascinated by the systems that organize our world, that facilitate life for some and leave others out. Why was it, for example, that because I was born into a wealthy family in the United States, I had access to the medicine and care I needed to lead a healthy life, while a woman my same age somewhere else in the world could die because she lacked access to that same medication? With the naive belief that I could change these systems, I applied to a fellowship program and was matched with Integrate Health, an NGO working in Togo. I had to pull up Google Maps to figure out where it was. Togo is a small West African nation nestled between Ghana and Benin, home to 8 million people. This is the beautiful Kara River, and much of the country is lush and green like this during the rainy season. I lived in Togo for 2 years and have worked with my Togolese colleagues ever since. Togo has found a very special place in my heart because of its beautiful landscape, wonderful people, and great potential for change and prosperity. Unfortunately, though, the healthcare system in Togo doesn't work. 70% of the population, or 6 million people, lack access to adequate health care, resulting in maternal mortality rates 14 times that of developed countries, and 1 in 10 kids dying before their 5th birthday. This is because healthcare is too expensive for the majority of the population, it exists too far away from where people live, and nurses and midwives don't have the tools they need to provide good care. The status quo isn't working, but it doesn't have to be this way. My friend Josephine is proving that another reality is possible. 3 years my junior, Josephine and I lived in the same neighborhood in the outskirts of Kara, a northern Togolese city. When I met Josephine, she was newly pregnant and had recently found out that she was HIV positive. Josephine worked hard to get the treatment she needed to keep her and her baby safe, going to the clinic each month for checkups and medication refills, and participating in a support group for other HIV-positive expecting mothers. Josephine was filled with pride when she gave birth to a healthy HIV-negative baby daughter. Through this experience, Josephine saw the importance of dedicated primary care for pregnant women and young children, the most vulnerable members of our population. She was determined to make sure that women and children in her community had access to the health care they deserve. So she applied to be a community health worker and brought with her not just dedication and intelligence, but deep knowledge from her experience as a mother, as a patient, and as a woman that made her uniquely positioned to be an excellent health practitioner. Integrate Health hired Josephine, believing that in order to truly provide equitable healthcare, we must put the people we are serving central to the solution. Since 2015, Josephine wakes up early every morning to start work in her community. She walks door to door, greeting her neighbors, treating sick kids, and accompanying pregnant women. Josephine is part of a team of 95 community health workers, providing high-quality primary health care to women and children. Critically, they do not exist in a vacuum. When inevitably they are faced with a case that they can't treat themselves, or a pregnant woman is ready to deliver, they can refer their patients to the government-run health clinic nearby. Integrate Health invests in these clinics, ensuring that medicine shelves are stocked, nurses and midwives are supported, and that care is free for patients, the majority of whom couldn't afford it otherwise. This community and clinic integrated approach is working. In the communities where Josephine and her colleagues work, more women are giving birth at the health center instead of at home. The frequency and speed at which sick kids are being treated is increasing. And most significantly, our research is showing that the mortality rates of kids under 5 is decreasing dramatically. And this isn't because of some innovative new technology or cutting-edge medicine. This is because we have designed a delivery system where known solutions like $5 anti-malarial medicine or amoxicillin actually reach poor communities left out of the current structure. And it's working because women like Josephine are right there in the middle of it, taking control of their own health and shaping the health of their communities. Our work in Togo shows that health for all is within reach, creating a world where everyone, everywhere, has access to high-quality healthcare is not a problem that needs solving. It's a solution that needs scaling. So the question isn't anymore what we need to do, but how. How do we ensure that this solution is scaled to every community that deserves it? We must design health systems with women at the center. Now, why do I say this? Well, health and gender disparities do not exist in separate silos. They interact and reinforce each other. If we do not actively address gender inequality while designing our health systems, we will recreate that inequality. Health for all will benefit women less. So how do we do this? Well, for starters, we must hire women like Josephine at every level of the health system and especially in leadership roles. We must design our technology so that it's accessible to women, perhaps by producing materials in local language or providing childcare at trainings. And most importantly, designing health systems with women at the center requires valuing the opinions and experiences of women and including them in data collection. For Integrate Health, this looks like routine community meetings where community members have the floor to ask questions and provide feedback to our team and the government. The participants are predominantly women, demonstrating their leadership and commitment to the health of their families. And then we genuinely act on that feedback, improving our programs. Another key example of how we practice women-centered design is through our community health worker recruitment process. In Togo, like in many countries around the world, community health worker programs predominantly hire men by default. We bet that there was enormous untapped human potential in rural Togolese women who were smart and motivated and capable, though they may not have had the opportunity of a formal education. We faced criticism when we announced our decision to prioritize women in the hiring process. Many of our partners just thought that we couldn't find enough women who could do or wanted to do the job. The recruitment took determination, patience, and meeting women where they physically were, but it bore fruit. Today, our community health workforce is 90% women who consistently exceed our quality of care targets. We were surprised, however, by the dramatic ripple effects we saw beyond our immediate goal of health provision that resulted from our hiring of women. For example, with their new source of income, women self-organized savings and loans groups and invested that money in other income-generating activities in their community. Women explained to me that their jobs gave them newfound senses of self-worth, and in some case, it transformed their relationships for the better. One of these women is my colleague, Esther. On Esther's first day of work, her husband assaulted her and stole her work supplies. He believed that she must have slept with someone to get the job. Undeterred, Esther showed up for work the next day to serve her community, and every day since. When I talked to Esther about the incident about a year later, she told me with a confident smile that everything about her home life had changed. She explained that before her job, she had no source of income and therefore no decision-making power. When her son was sick, she had to wait for her husband to get home to ask him for money before taking her son to the clinic. Now, she seeks treatment for her son straight away. She pays for her daughter to go to school, no questions asked. With her financial capital comes decision-making power. And as her husband watches her become a more equal member of the family, he started treating her with more respect. By promoting women at the center of health delivery, we are seeing the status quo shift on other axes as well, towards economic empowerment and gender equity. Come back with me to the banks of the Kara River. Universal access to high-quality healthcare is starting to become a reality for the 6 million people in Togo left out of the current system. But Togo is just the beginning. 3.8 billion people, half the world's population, lack access to essential health services. Our work in Togo is part of a global movement towards universal health coverage. This is what motivates me. As you can probably tell, I'm not in Togo right now. I'm in Oxford this year, continuing my studies. My goal is to strengthen my leadership skills so that I can better amplify the voices of the women who are leading the movement towards global health equity. I'd like to leave you with an invitation. Many concepts that we take for granted now as self-evident were once radical ideas. I've shared some radical stories with you today, stories from my life and Esther and Josephine's lives. Health for all is possible if we listen to and amplify the voices of women leading this movement and design our health systems with them at the center. I invite you to join me in sharing this message loudly, sharing it often, until this radical idea becomes self-evident. Thank you.